Welcome to the discussion of the Uworld question ID 16143. The personal history of the patient. He is 72 years old. He is male. He is South Korean. He immigrated 20 years ago. He was 52 years old when he immigrated, which means it's never too late to travel to USA. Do not lose hope. He is not a smoker. He doesn't use alcohol. Being old, 72 years old, and being an immigrant from South Korea raised suspicion for gastric cancer. After adding up the symptoms we are going to speak about in the next slides. Both medical history include hypertension, but it was controlled with chlorthalidone, which is a thiazide. He doesn't use any over-the-counter medications. What they mean by this is chronic usage of non-steroidal anti-inflammatory drugs, which play a major role in developing peptic ulcer in some cases. So, non-steroidal anti-inflammatory drugs usage is excluded in this case. He came to the office due to pain and weight loss. So, let's analyze this pain. The pain is in the upper abdominal region. He didn't specify which third, but I'm expecting it to be in mid-epigastric region. He didn't say anything about the onset or character or radiation. Character, I'm expecting it to be burning. The radiation, and also character, along burning, it might be gnawing pain. Radiation, it's not radiating to the back like pancreatic diseases. I'm not expecting it to be radiating to the back. It's associated with weight loss, and this is an alarm symptom. There's no dysphagia. Dysphagia is also an alarm symptom, but it's excluded. There's no melena, there's no rectal bleeding. Nausea, vomiting, and diarrhea. He didn't say anything about them, but the physician should have asked about it, and this information must have been included. That's why I'm putting question marks in these things. What exacerbates this pain is eating, and it's relieved by antacids. Antacids relieves pain, indicates there is some form of acid production, excess acid production, or decreased mucosal barrier to the normal acid production. So, the site in the upper abdominal region somewhat exclude the cancer, as written in the explanation of the Uworld, and using antacids relieving the symptoms excludes ischemia, mesenteric ischemia. Mesenteric ischemia also happens after eating. It's exacerbated by eating. But relieving by antacids is not typical for this. And as well, you can exclude gastroparesis because there is no diabetes associated with it, and antacids relieves it. I'm expecting something related to the acid production. The vitals are within normal ranges. The BMI, it's not a vital, but it's underweight. It's abnormal. 17.2 is underweight because it's below 18.5. This indicates the weight loss. It's not related to the vitals, it's related to some calculations or some numbers. By examination, there is normal cardiopulmonary examination. There is no liver or spleen enlargement, so this somewhat excludes portal hypertension. There is an epigastric fullness and tenderness. When there is a tender epigastrium, you think about pancreatic and gastric diseases, and pancreatic is even more. Gastric ulcer only in 20% causes tenderness, and it's somewhat or somehow associated with perforation, so keep that in mind. The fullness of the epigastrium is discovered by percussion, while tenderness by palpation. Just keep these things in mind. When you examine clinically, you do all the steps: inspection, palpation, percussion, auscultation. So, auscultating of the heart and the lung were normal, as indicated by cardiopulmonary examination. Normal liver and spleen is also by palpation. You make the palpation, you percuss the liver, and you measure the diameter, the longitudinal diameter, the upper border and the lower border, in the midline and in the periphery, in the midclavicular line and in the sternum. Anyways, just keep that in mind in the clinical practice. You assessed for dehydration despite the normal vitals. You assess dehydration, the mucous membranes are dry, but there is a full peripheral pulses in the pedal pulse or the radial pulse. They're full, they're strong, they're not weak or thready. The capillary fill is normal. It didn't extend beyond it's up to 2 seconds. More than that means there is dehydration or there is shock somewhat. Dry mucous membranes, I don't know exactly what caused this, but I assume it's due to the old age. Older age means less salivary secretion from the parotid gland and lacrimal glands as well. What's dry mucous membrane actually means? You assess dehydration in the mouth and the eyelids. And older ages makes the secretion less. This dehydration might be due to abnormal dosing of the thiazide diuretic, but like normal vitals and full peripheral pulses and normal capillary fill excludes any form of dehydration. I assume it's more related to the glands rather than something full. This is not dehydration, generalized dehydration. What am I expected to be done is CBC, to exclude anemia, to see if there's an anemia or not. Anemia is an alarming feature. I'm expecting it to be done. The stool analysis as well. It was not requested, but I'm expecting to see if there is a heme positive stool or not. This is an alarming feature as well. I don't know why it was not requested or mentioned in the case. Maybe abdominal erect X-ray be done. It can be done or not. I'm not sure. I added this myself because any epigastric tenderness is concerning for me. I'm speaking about myself. I would have requested abdominal X-ray. Erect to exclude perforation, because if there was perforation, you would see air under the diaphragm. This is a big story. Just forget about it. You can just forget about the abdominal erect X-ray. What about the CBC and the stool analysis? Why it was not requested? I'm not sure. The upper endoscope is also an investigation. If there is a gastric ulcer or duodenal ulcer or peptic ulcer of any kind, if it's duodenal or gastric, you perform an upper endoscope in certain situations. And you do H. pylori stool antigen in certain other situations. What are they? You would perform upper endoscope if the age is above 50, as in this case he's 72 years old. And there are alarming features like weight loss, which is present, anemia. That's why I asked why there was no CBC or hemoglobin at least. Heme positive stool, like where is the stool analysis? I want to request it. Dysphagia, there was no dysphagia, and this excludes this alarming feature. But there is weight loss, so you request an upper endoscope, and this was the right answer. If he's below 50 years old, there's no alarming features whatsoever. None of these four are present. You perform H. pylori testing by, you don't use serology because it's not specific for previous infections. So you use a stool antigen, and using stool antigen, when you perform this testing, stool antigen H. pylori, it might be positive, so you treat accordingly. If it was otherwise negative, you give an empiric PPI, proton pump inhibitors, and see. If it failed, then you perform endoscope. And that concludes the question. If you have any question or any addition to this information, any comment, do not hesitate to keep it in the comment section. Thank you and good luck.